Hello, my name is Sharad Wadhwani. I'm an affiliate member of the Philip R. Lee Institute for Health Policy Studies, and I'm an assistant professor of pediatrics at the University of California, San Francisco. What I find interesting as it relates to my research is what I'm interested in better understanding is how we can strengthen the provisions of social needs care for children undergoing liver transplant. So I'm a pediatric hepatologist, and I primarily care for children before and after liver transplant. A little background on transplant. When a child is diagnosed with liver disease, they're diagnosed in their community, and then they're referred to a transplant center for evaluation and consideration for liver transplant. Children with end-stage liver disease tend to be quite sick and are at risk for life-threatening complications like infections or bleeds. And so while they're awaiting liver transplant, they're in sort of a critical illness type of phase. And then following transplant, their disease physiology changes tremendously, and they recover from their life-threatening complications of end-stage liver disease, and they enter more of a chronic care model. They need to be on lifelong immunosuppression to protect their transplant from their immune system. And so as they enter this chronic disease phase of care, it becomes really important that they have ongoing surveillance, that they take their medications as prescribed, and that we continue to monitor for complications from the immunosuppression medications. And what we've shown in our previous research is that children after liver transplant are at increased risk of having graft failure or mortality if they come from more socioeconomically deprived neighborhoods. And we've also documented that there are racial disparities with regards to post-transplant outcomes. So one of the things that we're trying to do now is better understand how the social determinants of health impact outcomes after transplant. Specifically, we want to better understand the impact of material economic hardship, like housing instability and food insecurity, to better understand how these constructs impact children after transplant. Secondly, we're trying to better understand how patients and families experience their transplant care through in-depth qualitative interviews. And we're also trying to better understand how transplant teams, which are multidisciplinary teams that comprise nurses, surgeons, physicians, social workers, and the like, how they come together to identify and intervene on social adversity. Some of the early findings that we have uncovered are that patients and families are extremely motivated to care, to deliver the adequate and prescribed care that they've been, that the team has recommended, but that there are often challenges outside of their ability that impact their ability to deliver care. For example, sometimes we use liquid formulation of the immunosuppression medication, and that has to be made by a specialty pharmacy that compounds this medication. And one of the things that we found from talking with patients and families is that not every pharmacist knows how to make this liquid formulation of the medication. And so parents and families have developed really complicated schedules for figuring out when that specific pharmacist is going to be at the pharmacy, and the time when they call the pharmacy to make sure that the right medication gets made. And so I think as we think about how to strengthen our ability to deliver care that meets families at their social needs, we need to consider the additional hardships that some of our, as physicians and providers, that we don't typically think about when we prescribe medical regimens.